Welcome to this explainer. Today we are stepping right onto one of the absolute most intense physiological battlegrounds imaginable, the human body during severe trauma. I'm so excited to unpack this with you because it's just a fascinating, complex topic. We're going to systematically trace exactly what happens from the very split second a physical force impacts the body, all the way through to the massive internal crisis that follows. We've taken all the heavy medical science and distilled it down to map out this journey, so let's just jump right in.
To kick things off, let me ask you kind of a common sense question, right? Based on what we see in movies literally every day, if someone is in a horrible accident and goes into medical shock, their blood pressure drops immediately, right? The monitors beep super fast, the numbers just absolutely plummet, and boom, that's how the doctors know there's a crisis. I mean, it seems totally logical.
Well, actually, scratch that. It is completely wrong. In reality, hypotension, or low blood pressure, is one of the absolute last signs of shock. Our source material points out this really wild fact. Children and even really fit young adults can be in a state of profound, life-threatening shock while sitting there with totally normal blood pressure. The human body is just a master of deception when it's fighting to survive. It will literally clamp down its vessels, restrict blood flow to the skin and the gut, and completely hide the crisis from the outside world until the very last possible second.
Okay, let's quickly look at our roadmap. We are covering 1. The mechanics of trauma. 2. Hidden factors and injuries. 3. Defining medical shock. 4. The stages of shock. And 5. Principles of resuscitation.
Starting with Section 1, the mechanics of trauma, visualizing force and covert damage. Before a patient ever goes into shock, there's that initial insult. We really need to understand how physical energy actually transfers into and then travels through the body. Say you have a motor vehicle crash and a driver's knee smashes into the dashboard. The obvious injury is exactly where you'd expect, right? A nasty wound or bruise right on the knee. But the force of that impact doesn't just stop at the kneecap. That energy transmits directly up the femur, essentially acting like a giant battering ram, and can actually cause a fracture dislocation of the hip joint way up in the pelvis. So, the direct impact is in one place, but the covert, hidden injury happens somewhere else entirely.
This brings up a super vital clinical strategy known as the timeline concept. Basically, doctors have to act like forensic detectives. They have to use obvious external clues to anticipate these potentially lethal internal injuries. For example, a left-sided impact might just show some pelvic bruising on the outside, but the covert injury hiding inside could be a completely ruptured spleen. Or a lap belt causing a spinal fracture might actually be hiding a ruptured duodenum. It is all about tracking exactly where that kinetic energy went.
Moving to Section 2, hidden factors and injuries, blunt force versus ballistics.
Now, it's not just blunt force like a car crash that hides its secrets. Different mechanisms of injury play by totally different rules. There is a massive contrast here. While blunt trauma transfers force along your skeleton, high-energy ballistics, like a high-velocity bullet passing through a block of ballistics gel, induce this extreme lateral acceleration. What happens is it creates a massive temporary cavity that violently stretches the surrounding tissue way out, far beyond the actual path of the bullet. Now, this cavity only exists for literally milliseconds, so you won't see it during a normal clinical exam. But that immense internal destruction, it's already done.
Section 3, defining medical shock, pump failures and plumbing leaks.
So once that severe physical damage is done, whether from a blunt impact or ballistics, the body responds. And when that response starts to crack, we enter shock. Now, what actually is shock? As we learned earlier, it's not simply low blood pressure. It is a catastrophic systemic failure. It's when your body's cardiovascular and hormonal responses just completely fail to provide adequate blood flow, or perfusion, to your vital organs, which ultimately starves your cells of oxygen, leading to cellular ischemia.
I love how this breaks down because it classifies the failure so clearly. Think of it like a house's water system. This failure happens in a few distinctly different ways. If you're bleeding out from a trauma, you're losing fluid, right? That's hypovolemic shock. It's a plumbing leak. Your cardiac output is low, so your vascular resistance shoots way up to squeeze whatever blood is left into your core organs. But compare that to cardiogenic shock. Here, the plumbing is totally fine, no leaks, but the heart muscle itself has failed. That is a pump failure. The systemic crisis looks the exact same to the cells, but the mechanical cause is completely different.
Section 4, the stages of shock, the descent into crisis.
This is essentially the timeline of the body slowly losing its desperate battle against an injury, and systematically happens in 4 key stages. It starts with compensated shock. Here, the body is aggressively managing the crisis. It's literally sacrificing the non-essential stuff, shutting down blood flow to the skin, the muscles, the gut, just to preserve flow to the VIPs, the lungs, the kidneys, and the brain. But then, as more blood volume is lost, usually once you pass that 15% mark, that compensation starts to crack. You slip through mild and moderate shock until the whole system totally crashes into severe shock.
If we compare the two bookends of this process, the contrast is honestly pretty scary. In compensated shock, like we talked about earlier, the vital signs are incredibly deceptive. The patient is totally conscious, they have normal urine output and normal blood pressure. They might just look a little pale and have a fast heartbeat. But flash forward to severe shock, the patient is now anuric, which means their kidneys have totally shut down and are making zero urine. They have severe hypotension and they are comatose. At this point, the mask is completely off and the system is in total collapse.
Which brings us to our final part, Section 5, Principles of Resuscitation, the Clinical Intervention.
So how do medical teams actually stop this runaway train? Well, there is this absolutely crucial golden rule in trauma medicine. Resuscitation should not be delayed in order to definitively diagnose the source of the shocked state. Think about that. In severe trauma, waiting around for a perfect MRI or a flawless neat diagnosis is a fatal luxury. You just don't have the time. The clinical exam dictates the first steps. You have to assume the worst, which is usually active bleeding, and you start resuscitating while you investigate. But here is where we hit a really fascinating clinical nuance. Let's call it the fluid paradox. If someone is actively bleeding out, your first instinct is probably to just pump them full of high-volume IV fluids to get their blood pressure back up, right? Makes sense. But if a surgeon hasn't actually gone in and closed that bleeding vessel yet, pumping them full of fluids can actually make things worse. It dilutes the blood's natural coagulation factor so they can't form clots, it cools the patient's body temperature down, and jacking up the blood pressure can literally pop whatever fragile little clot the body had miraculously managed to form, just restarting the bleeding. Hemorrhage control has to happen right alongside fluid therapy.
And if that delicate balance isn't struck incredibly fast, we hit a truly terrifying statistic, 60%. That is the current mortality rate from multiple organ failure. Because if a patient stays in profound shock for too long, that cellular starvation triggers an uncontrollable inflammatory response. Even if you rush in and fix the initial broken bone or take out the ruptured spleen, the prolonged lack of oxygen causes the organs to just start shutting down, one by one.
So in isolated physical trauma, literally cascades into total systemic collapse. The lungs fill up with fluid, causing acute respiratory distress syndrome. The kidneys fail. The blood entirely loses its ability to clot, which is called coagulopathy. And finally, the cardiovascular system itself just gives out. This is exactly why early, aggressive identification and reversal of shock is the absolute top priority in trauma medicine. You aren't just treating a physical wound, you are racing the clock to stop a physiological domino effect.
We've seen how physical force travels like a literal shockwave through our bones, how ballistics can destroy tissue they don't even touch, and how the body will ruthlessly sacrifice its own organs in a desperate bid to keep the brain alive. But I really want to leave you with this one provocative thought. If the human body can hide such a catastrophic internal failure behind a mask of seemingly normal blood pressure and vital signs, what other secrets is our physiology keeping from us right now? Thank you so much for exploring the hidden, incredible mechanics of trauma with me on this explainer. See you next time.